A 65-year-old man with dyspnea and leg swelling.
A 65-year-old male with a history of hypertension, diabetes, and coronary artery disease presents to the clinic with worsening shortness of breath over the past 2 weeks. The patient reports progressive dyspnea over the past 2 weeks. Initially, it was noticeable only during exertion, but now occurs at rest. He has been waking up at night gasping for air, paroxysmal nocturnal dyspnea. He needs to sleep propped up with 3 pillows, orthopnea. He can no longer walk more than a block without feeling out of breath, fatigue and reduced exercise tolerance. Reports bilateral leg swelling that has worsened, especially in the evening. Denies recent chest pain, palpitations, or fever. He has a history of hypertension, diagnosed 10 years ago, type 2 diabetes mellitus and myocardial infarction 3 years ago, treated with stents. In physical examination, blood pressure, 140 on 90 mm mercury, heart rate, 95 beats per minute, respiratory rate, 20 per minute, arterial O2 saturation, 92% on room air. General appearance, mild distress due to dyspnea. Neck positive jugular venous distension, JVD, up to 8 cm. Lungs, bibasilar crackles on auscultation.
Please use earphone.
Heart, presence of an S3 gallop.
Please use earphone.
Abdomen, mild tenderness in the right upper quadrant. Extremities, pitting edema, 2+, up to the knees bilaterally.
What is the diagnosis?
Chest X-ray shows cardiomegaly and bilateral pulmonary congestion with interstitial edema. Electrocardiography, ECG, QS pattern in anterior leads. B-type natriuretic peptide, BNP elevated at 1,200 picogram per milliliters, normal less than 100.
What is the diagnosis?
Echocardiogram, ejection fraction, EF, of 35%, with left ventricular dilation and hypokinesis of the anterior wall, suggesting systolic dysfunction.
What is the diagnosis? The diagnosis is
acute decompensated heart failure, systolic heart failure, likely due to ischemic cardiomyopathy.
Pathophysiology.
Why crackles?
Left ventricle failure, incomplete emptying, elevated left ventricle end diastolic volume, elevated left ventricle end diastolic pressure, elevated pulmonary veins and capillary pressure, fluid leaks, into pulmonary interstitium and eventually into alveoli. During inspiration, alveoli that were collapsed or fluid-filled pop open, creating fine crackles, best heard at the lung bases.
Why dyspnea?
Left ventricle failure, elevated left ventricle end diastolic pressure, elevated pulmonary capillary pressure, pulmonary congestion and interstitial edema, impaired gas exchange, dyspnea.
Why orthopnea?
Lying flat, increases venous return, elevated pulmonary capillary pressure. pulmonary congestion and interstitial edema, impaired gas exchange, dyspnea, on supine.
Why paroxysmal nocturnal dyspnea, PND?
During sleep. Reabsorption of peripheral edema. Increases venous return. Pulmonary congestion. Impaired gas exchange. Sudden awakening with breathlessness.
Why easy fatigability?
Reduced cardiac output. Decreased perfusion to skeletal muscles. Impaired oxygen delivery. Early fatigue, on exertion.
Why legs edema?
Right-sided heart failure. Elevated venous pressure. Fluid transudation into interstitial tissues. Pitting edema.
Why distended jugular veins?
Right-sided heart failure. Elevated venous pressure. Distended jugular veins.
Why right upper quadrant tenderness?
Right-sided heart failure. Elevated venous pressure. Venous congestion in the liver. Hepatic enlargement/tenderness.
Why S3?
Decompensated heart failure. Filling pressure. Volume overloaded LV. Sudden deceleration of inflowing blood. A low-pitched sound, S3.
Why is hepatojugular reflux test positive?
Applying pressure to liver. Increases venous return. In normal RV, RV accommodates this by increasing output slightly, now sustained rise in JVP. But in failed RV, RV is already volume overloaded and cannot accommodate the extra return. Sustained rise in JVP.
Clinical tips. Crackles, or rowels, compare the sound to rubbing hair near the ear. Rowels are not cleared by coughing, distinguishing them from secretions. The S3 sound occurs during early diastole, just after the mitral valve opens and blood rapidly fills, a volume overloaded or dilated, left ventricle. S3 is a sign of elevated filling pressures and increased volume, often heard in decompensated heart failure. Best heard with the bell of the stethoscope at the apex, in the left lateral decubitus position, during expiration. Sounds like Kentucky, or deep trip, S1, S2, S3. Although S3 can be physiologic in young people and athletes, in adults over 40, it strongly suggests LV dysfunction or CHF. How to perform the test. Patient is reclined at 30 to 45 degrees. Observe JVP. Apply firm, consistent pressure over the right upper quadrant or mid-abdomen. A positive hepatojugular reflux, HJR equals sustained, greater than 10 seconds, rise in JVP by greater than 3 centimeters, when pressure is applied to the liver or mid-abdomen, about 20 to 30 seconds. Clinical relevance. Positive hepatojugular reflux is a specific sign of right-sided or biventricular heart failure, especially useful when jugular vein distension, JVD, is borderline or difficult to assess.